وثب.
السلام عليكم، مساء الخير. الساعة 7:31 الحين. في 6 participants بس، فراح ننتظر لين 7:35 وإن شاء الله نبدأ. السلام عليكم. صوتي واضح شباب؟
واضح مجد.
اوكي شكرا حسين. بسم الله الرحمن الرحيم. مساء الخير. My name is Majd Kubbara. We'll be starting the overview session now, inshallah. It's about the GI system, and we're going to go through all of medicine, surgery, radiology, and pathology. Bismillah. Our first topic is the peptic ulcer disease, and we'll jump right to the case. Does anyone want to read the case for us? Any volunteer? Volunteer, read the case. Okay, I guess I'll be reading. A 61-year-old woman presenting with consistent discomfort and significant weight loss. She had a tarry stool in the early morning, which she had never experienced before. She presented with a 2-month history of burning pain in the epigastric abdomen and chest, which radiated towards her back. Her pain worsened after taking aspirin and drinking coffee, and was relieved after taking antacids. She also reported nausea and vomiting. She expressed concern, especially because the food appeared undigested when she vomited. She also reported doubling her NSAID intake due to increased knee pain. So what are the key points here in this case is firstly, the patient's age, it's 61, so more diseases are common in the elderly. Consistent discomfort does not come and go, it's always there, and she's losing weight for some reason. After that, we see that she has tarry stool, and we know that this is a hint for something. And then we see that she has 2-month history of burning pain in the epigastric abdomen and the chest. So we know the structures that are involved here, and we can reach a differential later on. There was radiation towards the back. Pain worsened after taking aspirin and drinking coffee. So these are the aggravating factors. The relieving factors are taking antacids. So she has nausea and vomiting as well, and she has recent history of increasing her NSAID dose. Keep in mind that any noun or any hints can be beneficial for you in reaching a differential diagnosis. So digging more into the case's history, in the past medical history, she has had gastritis with Helicobacter pylori infection 5 years ago. It has been resolved by pharmacotherapy only, and she has frequent recurrence going on for the last 5 years. She had a heart attack 3 months ago, started taking aspirin ever since. Osteoarthritis for 3 years, been having NSAIDs for a long time now. She had acute pancreatitis 5 years ago, and it only resolved with pharmacotherapy without any recurrence. She had a COPD for 11 years, and she has diabetes and hypertension for 6 years. So we have here highlighted the H. pylori infection and the aspirin and the use of NSAIDs, pancreatitis, COPD, diabetes. So all of these are risk factors or complications of or having the same etiology as peptic ulcer disease, but we're still not sure about the differential diagnosis. So looking deeper into the family history, her mother passed away from gastric cancer at age 67, and her brother is still alive and well at 56 years of age, but he has a history of duodenal ulcers. So we have ulcers in the family, and we have cancer as well. He's also a heavy smoker. The patient's social history is that she has been divorced for 20 years. She has 2 children that she has raised by herself. She's been smoking for 30 years now, and after the diagnosis of COPD, she still has not quit smoking. So what differentials can we have? Can you name at least 2 or 3? Old patients, persistent pain, peptic ulcer, okay. Can you guess anything else? Possible GERD? Yes, very likely. Pancreatitis recurrence. Okay, this is good enough. And so as differential, we have GERD, gastritis, hiatal hernia, and peptic ulcer disease. So all of these occur in the same region as the pain that the patient is describing, but according to her history, we can reach one final diagnosis, and that is the peptic ulcer disease. So what is the etiology of peptic ulcer disease? It is a mucosal damage secondary to pepsin and gastric acid secretion. So usually the mucosa is not affected by the pepsin and gastric acid that's present inside the stomach, but now it is being affected and it's being denatured and damaged due to the disruption in the barrier that protects the stomach itself. So when the pepsin and gastric acid reach the mucosa, they start affecting it and it starts ulcerating. Most commonly occurs in the stomach and proximal duodenum. It does not occur distal duodenum because the acids will have been corrected into harmless pH levels due to the bicarbonate coming from the pancreas. So we're most afraid about the proximal duodenum. And keep in mind that the connection between the stomach and the proximal duodenum is the pyloric sphincter, and we'll see how that will be affected soon. H. pylori infection is also a big risk factor for it. It's an etiological factor, and also the use of NSAIDs are very predominant causes. Aggravating factors, you can see how many our patient has already: smoking, ethanol, bile acids, as in regurg back from the duodenum, and aspirin, steroids, and stress. So she had 2 kids to raise all on her own. Being in an age group older than 50 years is also an etiological factor. Having genetic predisposition, infection increases the risk as well. Associated disease, which he had many of, and it's including COPD, chronic liver disease, chronic renal failure, Cushing's, hyperparathyroidism, and coronary artery disease. So, as I said, they either have the same etiological factors as PUD, or sometimes the medication for one causes more risk for PUD. So the symptoms that a patient usually presents with: episodic gnawing or burning in the epigastric region, because that's where the peptic ulcer is usually at, pain occurring 2 to 5 hours after meals or on an empty stomach. Surely this is highly debatable, as when the pain is aggravated, is it on an empty stomach or is it on a full stomach? Uh, Whenever it is gastric, it's something, and whenever it's duodenal, it's something else. But there's been a lot of debate recently on this point. Nocturnal pain relieved by food intake antacids as our patient is taking, and this has been proven over and over again. Anti-secretory agents like PPIs. Less common symptoms that we see is indigestion, vomiting, loss of appetite, surely because they might be having pain, or due to the vomiting, whatever they eat, they would vomit. Intolerance of fatty foods, and heartburn as well. They could have GERD as well as PUD, and it is very common. Having higher acidity is also a risk factor for PUD. Positive family history. Now, can someone tell me why do they vomit in peptic ulcer disease? Could be due to the pain, yes, sure, of the presence of gastric content in the stomach or in the duodenum. But there's something else that makes them vomit. Decreases acid. Yeah, that's a complication, yes. When they vomit gastric content, it has hydrochloride, which is acidic. And the more they vomit, the more hydrochloride they lose in their body, which leads to metabolic alkalosis. But there's a reason why they start vomiting. Okay, in short, after continuous ulcerating, when there's a large ulcer and continuous over a long period of time, there could be a gastric outlet obstruction. As you know, where the most common area for peptic ulcers will occur, it could affect the sphincter, as we said before. Now, we'll be talking more about the obstruction. So alarming symptoms are this list, and for every symptom, this is the cause for them. We will see here the anemia, hematemesis, and melena is due to the bleeding, So not necessarily any ulcer means that it is bleeding now or actively. Some ulcers heal a little, some ulcers deteriorate a little. So if the ulcer is bleeding right now, the patient can become anemic. We'll see that in the lab results. He might be vomiting blood in the form of hematemesis or melena. They will not have fresh blood in the stool because it will get somewhat digested along the GI tract. Uh, Obstruction will lead to vomiting, and we know that the gastric outlet is being obstructed. This is an alarming symptom. The patient might get dehydrated or have an electrolyte imbalance, as our friend said. Uh, Anorexia or weight loss. So after recurrent deterioration and and death of the cells due to the ulcer, dysplasia occurs, and the sequelae carries on all the way to cancer. Persistent upper abdominal pain and radiating to the back. That means that there has been penetration, as in the pathology has reached all of the layers of the GI tract, and it is affecting the somatic nerves on the back. Most likely in the duodenum because it is retroperitoneal. So spreading up to upper abdominal GI pain, there could have been a perforation, blood and gastric contents or GI contents are going all around in the peritoneal cavity, which is a good culture for bacteria, and it will irritate all of the region there. Now, for investigations, we want to do CBC, looking for leukocytosis because of the inflammation that's going on, or anemia in the form of low RBCs or hemoglobin. Stool for occult blood if we don't see a fresh blood, a melena already. We can do an esophagogastroduodenoscopy to see the extent and severity of the ulcer, upper gastrointestinal barium studies, and the H. pylori infection testing. So for the testing of the H. pylori, we can do a serology or 13C urea breath test. You can go over the advantage and disadvantages of these tests. Most importantly are the fecal antigen test. It is very cheap and very specific. But if you want to go invasively, the best one is the culture. I can't see. Yeah, the best one is the culture. This is the treatment algorithm for peptic ulcer disease. Usually, like any other disease, you start medically, then you go surgically. You can go over this in detail. It is very beautiful and it will benefit you, inshallah. So when do we go for surgery? In general, if the patient cannot tolerate medications, if he is high risk for complications that we've mentioned already, and anyone who has a relapse after maintenance treatment, or he's a really refractory case, so we switch them to a surgery. If they have complications that do not respond to endoscopic treatment, either bleeding, perforation, pyloric stenosis, or a malignancy, these cannot be done with, these cannot be treated with an endoscopy, so we go for surgery according to the surgeon's opinion. Complications, sorry, the guidelines. Complications of PUD, hemorrhage, perforation, gastric outlet obstruction. So the gastric outlet can be obstructed by two ways. Either the ulcer becomes edematous, and the edema makes it much more bulky, and that starts obstructing the lumen of the sphincter, or with recurrent ulceration, what happens is that there becomes much more fibrosis around the sphincter, which leads it to constrict little by little, and with time it will start obstructing. Now, do you have any question about the PUD, or should I move on to the diverticular disease? I will not spend much time on diverticular disease. Clear. Diverticular disease. It wasn't explained to us extensively back in my year, but I'm not sure about you guys. So I'll go over it quickly, and you can stop me if you have any questions. Terminology. Okay, let's start with what is a diverticular disease. So it is a spectrum of disorders. They come in sequence. One is very mild, then they become more severe and more problematic. So the first one is, what is a diverticulum? We can see here, this is the lumen of the GI tract, and this is a pouch protruding from the GI tract, and it is still communicating with the lumen. And this pouch is blind; it does not lead anywhere. It's just there, and that's what a diverticulum is. It's just a pocket of gut. So why does it happen here, not anywhere else? The reason is, you can see these three muscles. These are longitudinal muscles. They give strong support, so the lumen cannot push it away. This is a strong point. So these three give us strong cornerstones for the gut. And we have the circular muscle here, muscularis layer, and this layer gives support, but not as much as the longitudinal ones. And the arteries go into the muscle here and at these points specifically, and this makes a gap in the muscle, which makes an even weaker point for the lumen to protrude through. And this is what happens with diverticulum. So the diverticular disease is the sequelae, or the stages of diverticulum. First, it starts with diverticula, which is just having a pouch, an empty pouch with no other pathology in it. Uh, Diverticular are the pouches, and diverticulosis is having these pouches present in the body. Diverticulitis is when bacteria uh, stagnate there and they start making an infection, and that is when we need to interfere. So we have another case here. Anyone who wants to read? Anyone?
Yeah.
اتفضل.
Mr. Smith is a 64-year-old male who presented to the emergency department with a sudden onset of abdominal cramping, pain, and distension accompanied by fever and nausea. Symptoms began 24 hours ago. He also admitted to having two episodes of diarrhea in the past 24 hours that was blood streaked. He scored his abdominal pain as 6 out of 10. Mr. Smith denies any recent falls or injuries to the abdominal area.
Thank you very much. What do you think are the important points here?
Okay. Uh, it is sudden onset.
Yes, okay.
And
Second
he's
onset.
يعني 64 male.
Yes, age. Okay,
Age, yes. Also, there is a fever.
sure.
Mm. Some, yeah, and acute.
It's an acute because it's only started 24 hours ago. Anything else?
There's blood in the diarrhea.
Okay, very good. And there is no other reason for this to happen. So there's no clear reason why
Yes.
the patient is having it. All right, thank you very much. And reading into the past medical history, so this patient, he's obese, okay, he's very old, and he's very overweight. His BMI is 35 ever since he was 41. He denies regular cardiovascular exercise. He's had diverticulosis diagnosed with routine colonoscopy at the age of 50. He's had hypertension, and he's on medication for it ever since he was 47 years old. He has type 2 diabetes with only pharmacological management. He was diagnosed with the diabetes when he was 58. So no exercise. He has diverticulosis already. He has hypertension and diabetes. Okay, reading into the family history. Mother deceased at age 86 from stroke, and also history of diverticulosis or diverticulitis, so diverticular disease in general. She had both stages. Father at age 83 passed away with an MI, had a history of coronary artery disease, and sister's alive and well, but she has a history of obesity and diverticulosis. So almost everyone in his family has diverticulosis. For his social history, what we need to focus on here is the being a bank manager. So he had a desk job for 30 years. So he sits down a lot, and he does not exercise intentionally, and he does not exercise for the sake of his job. That leads to a very bad lifestyle. Smoker, and he's been smoking half a pack a day since he was 16 years. And he states that his diet consists mostly of meats, cheese, breads, and does not enjoy eating vegetables or fruits. So, for his social history, the being sitting around the whole day and not eating well, this leads to what? It leads to um, gastric GI content, or let's say feces, accumulating in the colon, and that leads to increased pressure. And if it stays there for long periods of time or chronically, it starts pushing away the wall and leading to pouches. This is only a theory; it has not been proven, and there is no clear etiological factor for this patient, for any for diverticulosis in general. But the funny thing is that when a pouch happens here, remember that this is an entrance or a pathway for the arteries that were here before. And these arteries can be damaged, and this will lead to bleeding. And that is one of the most common symptoms patients present with diverticular disease. So for his vital signs, his temperature this is elevated. This is around 39 Celsius. And he has a high heart rate, high blood pressure, as he's been diagnosed with hypertension. And his respiratory rate is a little elevated as well. His pulse oximetry was fine, is normal. So for his general appearance, most importantly, he's in pain, guarding his abdomen throughout the interview. His abdominal examination made it sure that there is firmness and tenderness upon the palpation in the left upper quadrant. He had no rebound tenderness. So everything else was normal. So what does this exclude? No rebound tenderness. Where do we see rebound tenderness? And what does lower upper quadrant pain give us a hint for? Appendicitis has been ruled out. Yes, rebound tenderness is in peritoneal inflammation. It's more left for sigmoid. Yes, sure. Sorry, rebound tenderness is usually for for appendicitis. Yes. Left for sigmoid, yes, sure, the sigmoid colon is in the left region, but it is in the left lower region. He could have diverticulosis everywhere, but the diverticulitis happened in the left colonic flexure. So these are our differentials. Only diverticulosis, but we can rule this out because he had fever. He wouldn't have fever if it's just simple diverticulosis. Diverticulitis, very likely. And IBS, irritable bowel syndrome, does not cause fever, and it's a chronic issue. It has a slightly different presentation. Appendicitis, we've just ruled it out. So etiology for diverticulosis, mainly by lifestyle and environmental factors, as I've explained. Low fiber diet, rich in fat and meat, just like our patient. Obesity, increased age, and low physical activity, just like our patient. So the case is very straightforward. We can see the diverticula are usually coming in multiple. Not necessarily all of them will become inflamed and turn into diverticulitis. Most common is the sigmoid, as our friend has just said. Pathogenic mechanisms are poorly understood clearly, but they are related to complex interactions like the colon structure, the motility, diet, and genetic factors. Most of what you hear are the diet and the genetic factors. And remember, they will present with bleeding because otherwise they probably will not have any other complaint. So how can we differentiate between diverticulosis and diverticulitis? I told you the main points, and you should know about diverticulosis. A few points are the bright blood when it is left-sided and darker when it is right-sided, because right-sided will have more time to be somewhat digested along the column. Diverticulosis is more severe, nausea and vomiting. You can go over the symptoms in detail, but most importantly, they have fever. Investigations, this is a colonoscopy. You can see this is the main lumen that we have, and these are the diverticula. happening here. They're all on the same line because in the other areas, we have the longitudinal muscles. So this is a weak point, a weak line, let's say, and the reticula can occur here easily. If we follow these, they will lead to dead ends. So diverticulosis, we can investigate for it using routine labs, looking for leukocytosis mainly, and anemia. CT abdomen and pelvis with IV contrast is also very preferable and very specific and highly sensitive. Keep in mind that do not use colonoscopy for active diverticulitis because that might lead to complication of the case like perforation or any other serious sequelae. This is the management. What you need to know is that it is mainly asymptomatic and we just fix the lifestyle. And the more severe, the more intervention that we'll have. You can go over this later. Now, principles for the surgical procedures. We can do a Hartmann's procedure. This is the safest option. And we can do a consecutive or a following anastomosis. We'll talk about that later in detail. Primary anastomosis can be done considered the patients. So we just resect the part that has the diverticulosis or diverticulitis, and we attach the proximal and distal colon together. Primary anastomosis, that's what it's called. Elective resection may be offered for recurrent cases. Definitive treatment of colovesical fistula will require resection. Some fistula can occur between the colon and the bladder, and you will need surgical intervention there. That was it for the diverticular disease. This topic is more important, in my opinion. And we will talk about colon polyps. So this is a case. Anyone, any volunteer? It's okay to have the same guy. I don't mind. Was diverticular disease clear?
I can read.
Okay, go ahead.
On routine screening, a 70-year-old man is found to have positive fecal occult blood test. He is asymptomatic but has a family history of large intestinal cancer. Abdominal and rectal examinations are normal. A colonoscopy subsequently reveals a polyp in the descending colon, but no other abnormalities.
Okay, what are the important points here?
So he's 70-year-old male, and has fecal occult blood, positive, but asymptomatic, and has a family history of large intestinal cancer.
Okay, and he did the colonoscopy already, and we saw the polyps with our own eyes. Thank you very much. Carry on from here. As a differential diagnosis, what do we have? We already said he had polyps, but what other pathologies can we think of? Anything else? Bleeding, elderly. Well, we've already said that we've seen the polyps already, so yeah. He could have colon polyps, or they could have turned into colorectal cancer. He could have hemorrhoids, anal fissure. These will lead to hematochezia. And he could have IBD, inflammatory bowel disease, whether it's Crohn's disease or ulcerative colitis. So polyps are projections arising from the colonic mucosal surface, the mucosal surface. Polyps may be neoplastic or non-neoplastic. Histopathology is required to confirm the nature of the polyp. So histopathology is our gold standard for diagnosis. Pathophysiology of the polyp, the adenoma carcinoma sequence is well established. So they start as an adenoma benign, then they turn into a carcinoma. The genetic basis of the adenoma carcinoma involves a double hit sequence, or they can happen simultaneously. So there's deactivation of both the APC gene and a series of further genetic mutations like the KRAS and the P53, with polyp becoming increasingly dysplastic and subsequently invasive. So as a classification, this is very important. So we have a protrusion into the lumen of the colon, and this protrusion can either be neoplastic, so there's a new type of cells going on here, or non-neoplastic, so cells that are normally present, but for some reason they're going into the lumen. Neoplastic types are the adenomas, most common, and polypoid adenocarcinomas, and lipomas or leiomyomas or lymphomatous polyps. So anything in the mucosa or submucosal layer can push it into the lumen. But non-neoplastic types are the hyperplastic polyps. There's just a bigger number of cells. Inflammatory polyps, usually in the ulcerative colitis or even in the in Crohn's disease. So same number of cells, but there's more edema and inflammation, which leads to the protrusion into the lumen. Lymphoid polyps or hamartomas, a benign overgrowth of tissues, normally found at the site, commonly in Peutz-Jeghers syndrome. So a lymphoid polyp, so there is lymph nodes involved here. Hamartomas is the exact same, the lining of the gut becomes disrupted, like in Peutz-Jeghers syndrome. So imagine having sheets of paper stacking up on top of each other. They will not be very high, and if you stack them up normally, but if you crumple them up and you try to put them on top of each other, they'll take more space and become much higher. So this is what happens. This formation or malformation that happens in Peutz-Jeghers syndrome is called the hamartoma, and it can be seen in other areas in the body for other diseases. As a classification for the morphology, surely it can be done with histology, and we have the first type is tubular, containing at least 75% of the polyp as tubules. If it's 75% villus, we call it villus. And if it's somewhere in between, so either 75%, so very high majority is tubular, so it can be called tubular, or very high majority is villus, so we call it villus. Or if it's somewhere in between, we call it tubular villus. And these are not very common. Most common is the tubular. Least common is the villus. And there's also microtubular, also tubules, but they're very small, and serrated or combined, as in serrated and villus. All types of adenoma are dysplastic and pre-malignant, although adenomas with a significant villus component are more likely to become malignant. Which one is more likely to become malignant? The ones that have more villus. And thankfully, this is less common. You can go over your slides in the pathology lectures. They have very beautiful images there. So what etiologies do we have? Increases with age, just like our patient in the case. Certain inherited disorders like that predispose to adenomatous disorders, like the familial adenomatous polyposis or Peutz-Jeghers syndrome. What do we see in Peutz-Jeghers syndrome? What type of morphological classification? Hamartomas. Gardner's syndrome, having polyps, and in another area, I believe it was the mandible. I'm sure it's the mandible. Familial adenomatous polyposis is autosomal dominant condition caused by germline adenomatous polyposis coli, the APC gene that we've talked about. So this gene is already disrupted, and well, ever since the child has been born, he's had it, and he will develop the polyps. And it is characterized by having hundreds to thousands of colorectal adenomas. I remember there were images for this one in the lecture. Nearly 100% risk for colorectal cancer. by age 40 if prophylactic colectomy is not performed. So the reason for this increased risk is because he's having hundreds and thousands of adenomas. So if not the first one, it's the second one. If not the second one, it's the third one that will turn cancerous. Peutz-Jeghers syndrome, it is also autosomal dominant, caused by germline ESTK11 gene mutations. It could be inherited, or it could happen in de novo, as in the patient is the first one in the family to ever have it, so he will develop the mutation there himself in his own body, not inherited from his family. Features include, it is hematomatous, as you have said, and I'm sure you will never forget this. They would have mucocutaneous pigmentation around the body because it's a syndrome, so it's affecting several systems. Lifetime cancer risk is reported to be as high as 90%, including gastrointestinal and extraintestinal malignancy. So adenomatous is having a higher risk, but this one can go extra intestinal. And the familial adenomatous polyposis can be diagnosed early, and early resection is preventive. Diagnosis for polyposis. So it can be done clinically, but then you'll need following a follow-up with examination, and our gold standard is the endoscopy, or even with radiology can identify it. Determining nature of the polyp and ruling out cancer by histological examination is a must. We need to make sure that this is either cancerous or non-cancerous with the histopathology. Symptoms and signs of polyps: rectal bleeding, iron deficiency anemia. Rectal bleeding, like our case, right? He was bleeding per rectum. Iron deficiency anemia due to the bleeding, change in bowel habits due to the change in the shape and in the shape of the gut and the colon. Tenesmus and mucus discharge. Tenesmus is when the patient has many polyps in the rectum. He wants to defecate, and he might defecate a little, but he will still have the urge to defecate again. And the reason for that is that the distension of the rectum is not caused by the presence of feces, rather it is being caused by the presence of polyps, and polyps cannot be defecated, so they stay there, and the nerve signals still fire to telling him that he wants to defecate. He might have mucus discharge, because remember, polyps are protrusions of they happen in the mucosal surface, so he'll have more surface area and more mucus secretions. Symptoms of polyps are more or less the same as those of colorectal cancer. Surely they sequence each other. Risk factors: increasing age, previous history of polyps, family history of polyps, inherited bowel disease, because they will make, whether it's an inflammatory bowel disease or any other bowel disease, such as familial adenomatous polyposis. Male gender and acromegaly are weak factors. Acromegaly, if you remember, this plays a role in the growth hormone, so they could have more growth hormone that affects the colon, and that leads to more growth of the cells, which leads to polyps. Investigations: we might see fecal occult blood, because these polyps can bleed, but this is only for screening. So if we see if we see blood, okay, we're sure that he has blood already. But if we don't, we go for the fecal analysis. We see it for screening. If it is positive, we need to make sure we need to do the colonoscopy and the other investigations to rule out cancer. We can do colonoscopy for sure. Flexible sigmoidoscopy, double contrast barium enema, as in for the imaging. Virtual colonoscopy, we'll see a picture for that, and CT colonography. Histology is the gold standard to determine the type and morphology and degree of the dysplasia this patient has. So this is the virtual colonoscopy. So the scope goes in, it takes its readings, and it projects them. It It draws a 2D or 3D image, and the radiologist sees it, and he can decide. This is less. It's more tolerant for the patient. This is less tolerant for the patient. The regular colonoscopy. This is a colonic adenoma. It is very clear. It is obstructing like 40% of the lumen. This goes on much longer. It might lead to other pathologies that we will discuss later. How do we manage polyps? They have to be removed to exclude the malignancy first with the histopathology, or just manage the symptoms and the complications that they are causing. So usually by the endoscopy, we do a mucosal resection or an endoscopic submucosal dissection, depending on the extent of the polyp. Surgical resection is recommended if a polyp has any malignant features. If you have just an adenoma, a benign adenoma, you do not need to do a resection right away. So prognosis, recurrence is very common, also depending on the disease. If he has familial adenomatous polyposis, you'll never be done with his adenomas, so resection is recommended. Not all adenomas become adenocarcinomas. So the patient is at the end of his life and he has many other comorbidities, and you do not want him to enter a surgery just because some of his adenomas are becoming adenocarcinomas. So complete colonoscopic clearance of adenomas has been shown to decrease the colorectal cancer incidence by 70 to 90%. That's cool. So we are avoiding the transformation into cancer. Majority will remain asymptomatic throughout the patient's lifetime, so do not be hasty with the surgery. Prevention of colorectal cancers through the screening of asymptomatic population and surveillance according to risk is recommended. So if you remember our patient, uh, he was diagnosed with routine colonoscopy for his risk factors and history and the family history, I believe. And that's how they diagnosed his polyps. Colorectal cancer. Any question about the polyps? Colorectal cancer is a continuation of polyps because they transform into the colorectal cancer. Any question about polyps? Am I going too fast? Are you guys here or not? Okay, Faisal says clear, thank you. I hope it is. So we have another case. Anyone who wants to volunteer to read? Reading case, colorectal cancer. I'll read it through. 70-year-old man presents to his primary care physician with a complaint of rectal bleeding. He describes blood mixed with his stool and a change from his normal bowel habits as he is going more frequently than normal. I think we've seen this somewhere. He has also experienced some crampy left-sided abdominal pain and weight loss. He has previously been fit and well, and there is no family history of gastrointestinal disease. Examination of his abdomen and digital rectal examination are normal. So first, what are the important factors that we see here? We see his age, 70 years. He has rectal bleeding. As we know, polyps can bleed, and so does colorectal carcinoma, even diverticulosis, if you remember. He's seen the blood. He has change in the bowel habits, and he has crampy left-sided abdominal pain and weight loss. This is very important for diagnosis of cancer. He has been previously fit and well, but with no other complaint and no family history of gastrointestinal disease. His examination was normal. Okay, what are some differential diagnoses that we can have? I think I mentioned a couple. Can you guys tell me? Interaction. ulcerative colitis, possible. Divertical disease, yes. Think wide, nice. So, colorectal cancer, irritable bowel syndrome, inflammatory bowel disease, hemorrhoids, anal fissures, diverticular disease. Yes, good job, guys. So, majority of the colorectal cancer are adenocarcinomas from the epithelial cells lining the colon and the rectum. Less common types of malignant colorectal tumors are carcinoid tumors, GI stromal cells, and lymphomas. Each one of these has a different progenitor cells, but the most common one is the adenocarcinomas. So these come from epithelial cells. Epithelial cells, adenocarcinomas. These arise from dysplastic adenomatous polyps that we've talked about just a while ago in the majority of the cases. Multi-step process, so we have the inactivation of tumor suppressor genes, so we have no breaks here, and we also have the activation of oncogenes. So someone is stepping on the gas, and he has no brakes, so the cells will go crazy. They result in selective growth, advantage to the colonic epithelial cells, and drives the transformation from normal colonic epithelium to adenomatous polyp, then to invasive colorectal cancer. So these sporadic cancers arise from stepwise accumulation of somatic genetic mutations. So these are the cancers that have no specific pattern. But the germline mutations, they underlie the inherited colon cancer syndromes, like the Poyst-Jiggers and FAP and Gardner syndrome. So these have a pattern, but the sporadic ones, they go through the process one by one, the genetic mutation and the whole story from start to finish. The mutation in the APC tumor suppressor gene is responsible for the dominantly inherited syndrome of FAP, right? APC, FAP. Now, the disease is seen when the inherited mutation of APC allele is followed by second hit mutation. So this is familiar. We have two mutations, or the deletion of the second allele. So one allele is not enough. We need to have a second allele to be mutated or to be deleted. What was the other gene that we've seen in the polyps? We said we have the APC gene and another gene has to be mutated. We gave two examples. Sure. Yes, chaos. Thank you. This is the staging. You should go over it. You can read this one quickly, but you should focus on Duke's staging. It's been mentioned in your lecture. I believe this is a presentation of Duke's staging. So we have stage 0, only mucosa. Here, stage 1, it starts invading the muscularis layer. Here, it consumes all of the muscularis layer. Here, it reaches the serosa and fibrosa and the only regional. And here we have the distal metastasis, and this is when things get not good. Okay, risk factors for colorectal cancer. Surely they will have the same risk factors as the polyps, but much more severe because it is sequential. And so let's go over them. Increased age, APC gene mutation, Lynch syndrome. It's a hereditary disease, but it has no polyps. So called colorectal cancer. MYH associated polyposis. This is another gene. Hamartomatous polyposis syndromes like Poyst-Jiggers syndrome. We talked about this. IBDs, especially the ulcerative colitis, and lastly, obesity. So we have weak risk factors like the limited physical activity and lack of dietary fibers and the acromegaly. Remember that the limited physical activity and lack of dietary fibers were major risk factors for diverticulosis, but here it's the other way around. It's mostly genetic and age and other diseases. Okay, signs and symptoms. We'd have abdominal pain, surely. rectal bleeding or anemia, because they bleed just like polyps, maybe even more so. Change in bowel habits like diarrhea, just like our case. Change in the stool form, because there might be disrupted absorption, abdominal distension, weight loss, vomiting. These are alarming symptoms. Tenesmus, same pathophysiology as polyps. They're frequent with specifically rectal cancer. Physical examination might be normal unless the disease is advanced. The patient might have liver metastasis or abdominal mass may be found. So the abdominal mass might be a collection of many cancers near each other, making one big mass on examination. But why is liver metastasis common? Any idea? Usually do a digital examination to exclude masses in the rectum. This is a physiology question. Portal blood, yes. Portal vein. Thank you. So to take it from the colon straight to the liver. Yes. Thank you. Diagnosis. Fecal occult blood. This is for screening only. If we don't see it already, we need to do fecal analysis. CBC, same as before, for anemia or leukocytosis. LFT and RFT to establish a baseline, because most of the medications that we're going to administer might be nephrotoxic or hepatotoxic. Colonoscopy is the first line, of course, for diagnosis. And CT colonography, just like the polyps, if the colonoscopy was incomplete or refused by the patient's work. The double contrast barium enema is second line after the colonoscopy and CT colonography. It is safe and well tolerated. This because it's an imaging. There's no tube insertion. PET scan, sure, because it's a cancer. Confirmation of carcinoma is by histology. Sure, we need a biopsy to decide. So how will we manage a patient who has colorectal cancer? Surgery is the mainstay of curative method because it's already a cancer. Laparoscopically is preferred. You guys know what laparoscopy means. It means you open a small opening and you insert manadir, insert scopes inside the abdomen instead of opening the whole abdomen and doing your thing inside. He might need a stoma to be prepared before the surgery. Unresectable metastatic stage 4 or medically inoperable colorectal cancer, you will not go for surgery because it will not benefit the patient much. He will have more serious problems either way. So we'll go for palliative therapy rather than the curative therapy. We have the goals of prolonging the survival of the patient and maintaining his high quality of life. We would go for chemoradiotherapy instead of surgery. When do we do that? Either he's medically inoperable, he cannot tolerate the surgery, or he will not benefit from it due to his advanced stage in colorectal cancer. Complications to colorectal cancer, to the therapy. It might lead to bone marrow suppression, especially the chemotherapy. It might do some hepatotoxicity, which is why we did we established the baseline for his liver function tests. GI abnormalities like the nausea and vomiting, diarrhea, abdominal pain, regular other complications like the alopecia, rash, and fecal incontinence. Prognosis for these patients is dependent on the stages. If he's in stage 1, it can be up to 97% survival rate after 5 years. S2 can up to 85, S3 up to 83, and this depends on the lymph nodes involved. But the stage 4 are less than 8% after 5 years because their metastasis will compromise their life before the actual colorectal cancer. All right, we have intestinal obstruction now, or do you guys want to have a break? Any question about correct answer? Double contrast means you would insert a contrast from two areas, from two places. So you can do one animal and one Venus. So you can see the animal will give you a presentation of the shape of the lumen, how it becomes and how it's filled. We'll see more of it later. And the other one will show you where the blood is going most, because we know that cancer is highly demanding of nutrition, and that leads to the weight loss in the first place. And so you will see more angiogenesis occurring in certain areas. I hope that answered your question. Can you please answer mine? Do you guys want a break or no break? We'll go with a break, okay? 10 minutes. 10 minutes break, 10-minute break. Right. Assalamu alaikum. You guys ready? Please write in the chat. 10 minutes have elapsed. Let's start with intestinal obstruction, and I personally love this topic. We have a case. Can someone read it, please?
Yeah.
تفضل.
43-year-old female with history significant for exploratory laparotomy with splenic resection, 10 years prior presence with 2 days of abdominal pain with vomiting. She had 2 episodes of non-bloody diarrhea 3 days ago and hasn't had a bowel movement in the past 2 days. She reports passing no flatus during this time. Yesterday, she began having non-bloody emesis, and today she cannot tolerate any oral intake. On examination, you find an uncomfortable woman who is tachycardic and has a distended abdomen, diffusely tender to palpation without rebound tenderness or guarding.
Thank you very much. What do you think what do you think about this case?
Okay, the chronological order of the symptoms. Okay, 2 days يعني for abdominal pain with vomiting. لا, okay, she had يعني 2 episodes of non-bloody diarrhea 3 days ago, and hasn't had bowel movement after that. Then after that began having non-bloody emesis or vomiting. Yes, and the abdomen is distended.
So on day 1, there was no bloody diarrhea. On day 2, bowel movement has stopped and no flatus coming. And on day 3, there's non-bloody emesis. And today, not even oral intake is tolerated. Thank you very much for reading. We'll move on to acute intestinal obstruction caused by adhesions. So when did these adhesions occur, and why? Can anyone take a guess? Due to the surgical operation, yes. 10 years ago, they so this is a complication of the, or let's say side effect of the splenic resection. Any operation done on the abdomen can lead to adhesions occurring, which will result in obstructions later on. So this is an erect X-ray of the abdomen, and it revealed this appearance. What is the name of the sign that you see here? And what is the condition? Step ladder sign. Thank you, first. What is the condition? Small bowel obstruction. So step ladder sign, when you see a ladder, these are the steps that you have. These are the dilated loops, and the gas is accumulating upwards. So when the obstruction happens, you don't normally have gas, but it leaves a stagnant environment, perfect for the bacteria, the normal flora, to act on the food that you have eaten before. So this has for a long time to happen, and the result of the reactions is gas that we see here. So this gas starts accumulating. So the more gas that we have, we know that this case has started a long time ago. And the sign is called the stepladder sign, as you've mentioned, and the condition is a small bowel obstruction. So the pathophysiology here is the bowel distal to the obstruction has normal peristalsis and absorption until it empties everything and it collapses due to the intra-abdominal pressure. So there's nothing inside. Usually the GI content leaves it patent, but there's nothing inside anymore, so it collapses under pressure. The bowel proximal to the obstruction dilates with an increase in peristalsis to overcome the obstruction. In most cases of obstruction, especially the mild cases, there's an increase in peristalsis that happens in the beginning, and with increased peristalsis, the obstruction can be overcome. The adhesion can come off, or the foreign body or whatever the obstruction is caused by, it gets resolved spontaneously. The gases and fluids accumulate in the distended proximal bowel, and this leads the bowel to dilate even more and more. The venous return is impaired, so we have congestion and edema, so we have very high pressure at the site of the proximal bowel, and the arterial perfusion gets blocked because it cannot overcome the pressure that it has now. One second. Then we have loss of peristalsis, and the bowel starts becoming ischemic, necrotic, and gangrenous. Okay, so the comparison of signs of the signs in the acute intestinal obstruction. How can we differentiate between a small bowel obstruction and a large bowel obstruction? First of all, pain is both colicky. What does colicky mean? I'll answer this one. Colicky means the pattern of the pain and the nature of the pain, not the severity. So colicky means it is interrupting or recurrent. It's crampy, like it's a description of the peristalsis that's happening. Someone answered. Yes, it's related to the peristalsis. We have distension on the small bowel, but there's more marked distension in the large bowel. That is because the large bowel is already big, and when it gets obstructed, it gets even bigger and bigger. Vomiting is early in small bowel obstruction because the obstruction is proximal, and so the proximal bowel will gets filled up early, and that will lead to vomiting. But in the large bowel, it's late because the obstruction is very distal, and it will need a long time to fill up until the patient starts vomiting. And of course, constipation is the other way around. Constipation doesn't mean the inability to pass stool. It's actually not passing stool in the first place. So this will be late because the distal bowel will need a long time to empty the content it has, but it will be early in large bowel obstruction because there is little GI tract left to the defecation. Do we have a question here? If you would, yes, this is the definition of constipation. So either it is the normal range is 3 in 1 or 1 in 3. So 3 times a day or once every 3 days. Anything less than once every 3 days, that's constipation. Anything more than 3 times every 1 day, that's diarrhea. But comparison of radiological signs in the acute SBO. So we have 2 images. One is small bowel, the other one is large bowel. We just discussed the symptoms. Now we're discussing the radiological findings. In the small bowel, it will be central. The distension will be more central because that's where the small bowel is at. The large bowel will be peripheral. Not very necessarily peripheral because they can be moved. It can migrate to the center, but there will be distension in the periphery. That's for sure. In the small bowel, you can have it central without peripherally. You see the vulvae convenente. That's the pattern the small that the small bowel has. This pattern, and it is seen, I believe, endoscopically, but we see it very clear here when it gets obstructed and dilated. In the large bowel, we see the hastrations. These are the naturally occurring pattern of the large bowel, and they are very clear when when the bowel is obstructed and filled with gas. Here we see the bands are complete. So these bands, they span the bowel from end to end, from side to side, and this is because the nature of the small bowel is this way. These are the bands that are normally there. But in the large bowel, if you follow every line, let me zoom in on this. If you follow each line, it does not cross the span of the bowel. Why is that? Because we have something called tinea coli, and this is a band that is longitudinal along the large bowel, and it interrupts the bands that are happening here, the hostrations. The hostrations are not communicating from side to side, and this is why we see them interrupted, unlike the small bowel. These are the bands are regularly spaced between each other relatively. You can see that the spaces here are the same as the spaces here, distances between every band and the next. But in the large bowel, some here it is spaced narrowly, while here the spaces are much more distant. We see a coin sign here, which is specific for small bowel obstruction. Some people call it stack of coins. So if you stack coins on top of each other, you see that each one here is resembling a coin, and if you move your hand along it, you will notice the pattern that it is felt on the edge here. So it's like this is one stack of coin, this is another stack of coin, another stack of coin. I hope this one is clear. Okay, acute intestinal obstruction. The conservative management, gastrointestinal decompression by the nasogastric tube, because we don't want it to become more distended and perforate later on. We need to correct the fluid and electrolyte imbalance that the patient has, because his absorption is impaired. We give an analgesia or Foley's catheter or antibiotics per need per patient, however he needs. Surgical management will be required when multiple adhesions are found, but keep in mind that only the causative adhesion will be divided. Why is that? Because every time you enter to dissect an adhesion, you are accepting the risk of creating even more adhesions, which will be troublesome. So you leave the other adhesions inside to avoid further complications that are not needed now. Divisions of the other adhesions may result in further adhesions. I've said this. A second case. Can someone read, please? History and examination. Open the mic, it's fine. We're not that many. Okay, it's fine. I'll read it. So we have
Okay. 38-year-old male with no known past medical history or his hospitalization presented to the ED with a 3-day history of colicky abdominal pain, abdominal distension, nausea, and no passage of stools. Upon direct questioning, he also stated he had no passage of flatus for the last 2 days. There was no associated trauma, fever, diarrhea, vomiting, or any previous abdominal surgery. He had seen his family doctor the previous day, where a diagnosis of constipation was made and he was prescribed laxatives. On examination, the patient was in a slightly dehydrated state with normal vital signs. His heart sounds were dual and normal, and the lungs were clear with equal air entry. His abdomen was generally distended, tympanic to percussion with no shifting dullness sign. The bowel sounds were markedly reduced. No discrete masses were palpable, and diarrhea were relieved and empty rectum.
What do you think about this case?
Okay, there is obstruction.
What do you think about the case, not the diagnosis?
Okay.
What's the case about?
Yes. Okay. 3-day history of colic abdominal pain. There is distension, nausea, and no passage of stools.
Cool.
Okay, no passage of stools, and no passage of flatus. Okay, it's not infection.
Because there's no fever. Okay.
No fever. Yes. Also, his own laxatives. Okay,
What does that mean?
that means is there obstipation? Okay.
Constipation, yes. No passage of stools is constipation. But the
Yeah.
diagnosis was constipation alone, just constipation. That's why he was giving laxatives, but apparently it did not help. It only transformed into colic abdominal pain and distension. So what is important about the examination?
Yeah, the abdomen was distended and يعني percussion was tympanic.
Mhm.
ونو shifting dullness. Okay.
What does no shifting dullness? Yeah. What does no shifting dullness indicate?
Indicates there is no يعني ascites.
No ascites. Great.
Yeah.
Okay.
The bowel sounds were markedly reduced.
Mhm.
Okay.
And also he is also slightly dehydrated. So what part of our gut is responsible for water absorption?
A large bowel.
Yes. So this gives us a hint that the obstruction is at the large bowel. And the bowel sounds are reduced because they are distended and they're not moving the GI content anymore. Thank you very much.
Yeah.
And also the rectal examination was normal. This is an X-ray of his abdominal of his abdomen, and this has appeared. This. What is the name of the sign, and what is the condition? I don't know much. Coffee bean sign. What is the condition? Volvulus. Which part? Sigmoid. Nice. So the sigmoid colon, when it becomes convoluted, when it gets torn and volvulus happens, it extends in this direction. Otherwise, if it's in the right in the ascending colon, it would go in the opposite oblique line. So this is a case of sigmoid volvulus. Okay, talking about the obstruction in general, it's either simple or strangulated. A simple obstruction can be one of two cases. Either it is dynamic, so we still have peristalsis, but for some reason it is not. It's not moving along. Most likely, it's like a foreign body, or it becomes a volvulus, but not very severe. Only the lumen is occluded. In adynamic, we have blood supply, but we have no peristalsis. So simple obstruction, only the lumen is obstructed. Blood supply is not impaired. Dynamic, it means we still have motion, but still there is an obstruction to the lumen. And adynamic means there is no peristalsis. Sometimes even the lumen can be patent, but because there is no peristalsis, we would call it an obstruction. And I'm sure you've heard some cases about that, and you know some examples. So a strangulated obstruction is when both the lumen and the blood supply is impaired. So any obstruction compromises blood supply. Closed loop obstruction is a type of strangulated obstruction in which 2 points along the bowel are obstructed. So this one and this one. Instead of having only 1 point being obstructed, we have both points here and here. So we have this loop of bowel is completely isolated from the rest of the bowel. Same thing is happening with the volvulus. These are 2 points intersecting with each other, leaving separating one loop away from the rest of the GI tract. All right. Sigmoid volvulus is a form of closed loop obstruction that is due to torsion of the gut. So twisting of the gut around the mesentery. So normally we have this a broad mesentery going along here attached to the bowel, and when this is twisted, not only the lumen is obstructed, even the mesenterical blood vessels become impaired as well. So if the bowel gets twisted only 180 degrees, the lumen will be obstructed alone. If the obstruction completes a whole circle, 360 degrees, the mesentery vessels will become occluded. The causes could be due to adhesions, long pelvic mesocolon, so the mesentery are very long, and that gives it a chance to loop around or get storged, or narrow attachment of the pelvic mesocolon, so there's limited motion for it, and sorry, not limited motion, like the whole colon gets tethered to a tight spot. It's like you're holding a bag of groceries and you spin it, so it will become occluded and very easily. The handle will become constricted. But if you widen the bag, if you open it and you try to twist it, there is more range for the bag to move without the mesenterical blood supply to be impaired. Overloaded colon, like in cases of constipation or any problems with defecation, high fiber diet, and constipation, sure. Conservative management for sigmoid volvulus include a nasogastric tube for decompression, like the small bowel obstruction, fluid and electrolyte replacement, like our patient, he was dehydrated, analgesia and antibiotics if the patient needs them. Specific to volvulus, we need to do an endoscopic deflation by flexible sigmoidoscopy or rigid sigmoidoscopy, and insert flatus tube should be done before opting for surgery, provided that the bowel is not ischemic. If it is ischemic, you need to be more aggressive, and if it starts getting infarcted and gangrenous, you will need to resect it definitely. So for surgical management, we've seen this one before, the Hartmann procedure. It was in which disease? It was in the polyposis, familial polyposis, adenomatous polyposis. So, sigmoid colectomy with Paul Mikulic's procedure, this one. So these two ends will become stoma, as in openings to the outside world. This is the abdominal wall. They get connected to each other and to the surrounding abdominal wall, and they're left like this. While in the Hartmann procedure, you will have one stoma outwards, and the other end will be the rectum or the rectal stump. And later on, you will do a reanastomosis between the two. IBD. Is everything clear about the bowel obstruction? It's a very beautiful topic. Okay, thank you. Inflammatory bowel disease. These are two diseases, specifically the Crohn's disease and the ulcerative colitis. So we have many factors for these. Some are protective, some are risk factors for them. Cigarette smoking is protective for ulcerative colitis, while it is a risk factor for Crohn's disease. Breastfeeding is protective for both. Oral contraceptive pills are a risk factor for both. Appendectomy is protective for ulcerative colitis. High socioeconomic status are a risk factor for both. And it's most likely due to the social lifestyle that they have. NSAIDs are a risk factor for both. High sugar and fat intake, risk factor. Depression, risk factor. So people in poor communities usually are more protected than the people in high socioeconomic classes. I will be reading this case. So an otherwise healthy 22-year-old woman, age, presents with 5 months of low-grade fever, an 8 kilogram weight loss, and intermittent postprandial right lower quadrant pain, associated with non-bloody diarrhea 3 to 5 times a day. She also notes mild bilateral knee pain that is worse on awakening or after prolonged sitting. The family history is non-contributory, so it's not beneficial. Examination is notable for a temperature of 37.2 and moderate right lower quadrant tenderness with no rebound tenderness, no masses, nor What is the most likely diagnosis? Appendicitis, Crohn's, Meckel's diverticulum, ulcerative colitis. Crohn's disease. Anyone else? Terminal ileum, yes, that is a hint for us. So the age is a hint. It's more common in this age group. I believe it's more in males actually. They could have a low-grade fever. They're having a weight loss because they're having malabsorption. After the meal, she starts having peristalsis, so her affected right lower quadrant, which is the terminal ileum, is moving, causing pain. Non-bloody diarrhea due to poor digestion, to poor absorption of water content. Bilateral knee pain is an extraintestinal manifestation, and right lower quadrant tenderness is the same reason for right lower quadrant pain. And the answer is Crohn's disease. Thank you. So Crohn's disease, it's chronic inflammatory condition, may affect any part of the GI from mouth to anus. Patient age is usually 15 to 30, slightly higher in females also. I think I said males a few moments ago. So it's more common in females. What is the most common site of GIT that Crohn's disease affects? Our friend said the ileocecal, terminal ileum here. And it has its own skip lesions that we know. This is a lesion, then it skips a spared part of the bowel, and then another lesion happens here. Unlike ulcerative colitis, which we'll see soon. Yeah, ileocecal lesion. Now, Crohn's disease pathology has skip lesions. It can have fistulas, perianal fistulas between the lumen of the anus and the subcutaneous surface. We have luminal strictures happening due to chronic inflammation. On histopathology, we see a non-caseating granuloma. It is transmural. It is a transmural infection, inflammation. It's not an infection; it's an inflammation. And we have a creeping fat. There's an interesting pathophysiology why fat migrates from the mesentery to wrap around the intestinal structure. But clinical features, we have intestinal and extraintestinal. You can go over these. There are a lot, and you should know them because any case can have any symptom from any of these, and you will need to have Crohn's disease on the top of your list as a differential diagnosis. So, what is the most common extraintestinal manifestation of Crohn's disease? Iritis. You mean the anterior uveitis? It's arthritis. Thick usually because it's not managed properly. The one that you mentioned is it's independent of the course or the activity of the GI disease. So she could have a period of remission. So she has no symptoms, GI symptoms, but her eye symptoms will be persistent. However, the other extraintestinal symptoms or features will only be active when they have an active GI upset. Investigations and diagnosis for Crohn's disease, CBC, we'll see leukocytosis and maybe some anemia, renal function test, liver function test, ESR, CRP, calprotectin, stool analysis, ANTA and PANA. We could do an endoscopy to see the extent of the disease and severity, and also get a biopsy. We'd see an ulcer in the mouth or in the gums, or sorry, in the buccal mucosa. cobblestone appearance through the endoscopy can be seen. I'm sure you have clear images of those in your lectures. You could have pseudopolyps or patchy lesions. So pseudopolyps, they're like everywhere around them has been destroyed by the Crohn's disease, but they have remained. They have been spared like an island in the middle of the sea. So yeah, you see it as a polyp, but actually that is the normal level of the intestinal wall to be at. Other investigations include a barium enema and upper GI with small bowel follow through. This is also a barium study. So the patient has a meal, he drinks a lot of barium, and the images are taken of his whole small bowel to see the extent of the disease. Okay, we have a case with not much. Oh, we have a question. PSC. Not sure which one that is. What do you mean by PSC? Primary sclerosing cholangitis. The lesion can affect it directly. Oh, sorry. No, not that. That's the primary. There's another one. I forgot the name. It can cause both. I'm not sure why they happen together. They're just, as far as I know, they're just associated together. It's all in the GI tract, just hepatobiliary tract. It's very close, and the etiology of Crohn's disease is genetic. So yeah, it's not a local problem. If it reached the joints of the body, of course it would have the ability to reach the biliary tract. 25-year-old female diagnosed with Crohn's disease 2 years ago. She presented with paresthesia, cold extremity, and pallor. What is the cause? Iron deficiency, folate deficiency, B12 deficiency, vitamin B12, or diarrhea. C, B12. Yes, it is the most common, and these are common presentations for B12 deficiency. Complications for Crohn's disease, it could create a fistula from anywhere to anywhere, GI tract to GI tract, GI tract to another hollow viscous, or the surface like the perianal fistula, anorectal disease, fissures, abscesses, perianal fissures, bowel obstruction, malignancy, malabsorption of B12, cholelithiasis, nephrolithiasis, mainly due to the electrolyte imbalance and malabsorption, aphthous ulcers, toxic megacolon, and growth retardation due to the impaired absorption in children for nutrients. Management, sulfasalazine, more useful in ulcerative colitis, metronidazole. If sulfasalazine is not working, prednisone for the acute use. If metronidazole is not having an effect, go to immunosuppressants. These are the final resort for management. For surgical management, it is mainly reserved for the complications like the fistula, obstruction, and whatnot. Indications are these perforation and abscesses. Nutritional supplements, and sometimes these are given parenteral, so to bypass the problems of absorption in the GI tract. One more case. A 24-year-old male presented with 3 weeks history of bloody diarrhea, around 10 times per day. On examination, you noted multiple large ulcerative lesions over both legs. What do you think is the answer? We talked a lot about Crohn's disease. Now it's the turn for ulcerative colitis. So this is an extraintestinal manifestation. He has a bloody diarrhea, and it's been on for 3 weeks. This is ulcerative colitis. It starts affecting the distal rectum, and then it works its way proximally. So this is chronic disease of the mucosa on the ulcerative ulcers superficial. Unlike Crohn's disease, it is transmural. So patients' age is bimodal. They're most commonly in the third decade of life and in the seventh decade of life. No gender predominance. What is the most common site of ulcerative colitis? Naturally, okay, you really want to answer? Yes, rectosigmoid. Why is that? Because in mild cases, they would have the rectum only, and in severe cases, they would have the rectum and something else. So the rectum is common in everyone. That is why it is the most common. What is it called if ulcerative colitis involves the terminal ileum? We call this backwash ileitis. So it goes all the way back. It becomes pancolonic, and it starts affecting the terminal ileum. And yes, you were right. It is rectal sigmoid. So the pathology, there are no skip lesions. Unlike the Crohn's disease, the lesion is continuous. It is only in the mucosa, not transmural, and it has crypt abscesses. So these abscesses are happening in the mucosa, and it's like so. This is what happens. This is the shape of a normal colon, but in ulcerative colitis, we start having these crypts, having lots of neutrophils coming in, and these cause an abscess. This is like a crypt. So it's buried, like buried underground. But clinical features that we might see: hematochezia, abdominal pain, tenesmus, fever, anorexia, and weight loss. Extraintestinal manifestations are similar to Crohn's disease, but it has different rates of occurrence. So most importantly is the weight loss, sometimes abdominal pain, and the hematochezia. Same labs can be requested. You can do a colonoscopy. It is the gold standard for ulcerative colitis uh, to see the extent and activity of the disease. Other investigations can be ordered, like a plain X-ray in acute attacks to exclude colonic dilatation, SB, or whatever might happen. Now, complications. We might have iron deficiency anemia with the bleeding, hemorrhage causing us more anemia, electrolyte disturbance and dehydration, like our patient. Sorry, that was the patient for the vulvas, but yeah, same etiology here. Strictures, benign and malignant, colon cancer, sclerosing cholangitis, cholangiocarcinoma, toxic megacolon, growth retardation, just like Crohn's disease, psychosocial issues. These are the extraintestinal manifestations. Please go through them. For management, either medical or surgical. Medical, like the Crohn's disease, leave the immunosuppressants for lastly. They do not help much with active attacks. They're more preventative. Surgically is often curative, unlike Crohn's disease, because Crohn's disease is a systemic disease. So if you remove one part, you just removed a skip lesion, and another skip lesion might appear somewhere else at another point in time. But here, if you remove it, it cannot extend. You're stopping it in its tracks, and it will not extend to the rest of the bowel. But still, surgical option is indicated only in severe cases, unresponsive to medications, toxic megacolon, severe complications, and evidence for colon cancer or increased risk for colon cancer, growth failure, fulminant exacerbation, just a fancy word. It means very severe. That's it. It's not responding to steroids, causing an obstruction or a perforation as a complication. So, a compare and contrast between Crohn's disease and ulcerative colitis. Uh, This one, we talked about these, which is just a table to sum it up. Now, any question about ulcerative colitis or Crohn's disease? I did not read into that, I'm sorry. Calprotectin, it's part of the investigation. I'm not sure if it's even specific or sensitive. All right, moving on to GI imaging. Case 1. Outlook imaging. What is the view provided here in this patient? What is the view? Okay. A, so fine. All right. What is the name of the sign? And what is the most likely cause? You can have these images in the OSCE. Come on, everyone. Okay, I'll start answering now. So the view is supine, as you have said, and the name of the sign is regular sign, and most likely cause is a perforated viscous. So why is it supine? This is the best for overall appearance of the gas patterns in the abdomen, whether it is intramural or extramural. If it were so we can see that there's a lot of gas here, whether it's intramural or extramural. It's not going towards any direction, not up or right or left. So the patient is lying flat on his back, and the gas is coming forward. So that's why we see it very clearly. Regular sign is also called the double wall sign. So we see that the edges of the bowel are very clearly demarcated on both sides. This one is very, let's see, this one's very clear here. You see it, this edge is created by the air inside the bowel, and this other edge is created by the air outside of the bowel. So that gives us the hint of the diagnosis, which is a perforated viscous. All right, another image. What is the view provided here? You can see that there's gas. You can answer. I'm just talking. The gas is going in any certain direction. Correct. Okay, this patient is correct. It's going upwards. What is the name of the sign? Definitely not regular. Again, could be stepladder, cupola, or string of beads. Okay, it's not stepladder sign. This is a string of beads, and I'll tell you why. You know the view from the motion of the air. That's the only way to do it. So you can see that there's an air fluid level in almost all of these, although it is kind of flat. But if the patient was supine, they would be in perfect circles, and that's why we said that it is an erect view. Now, what is irregular sign? It is having air on both sides of the hollow viscous, and we do not see this here. A cupola sign is accumulation of air beneath the diaphragm, so making seeing a bubble of air here, right beneath the heart. It is beneath the diaphragm. When you see it on an image, it seems like it is beneath the heart. We do not see this here. Cupola sign would happen in pneumoperitoneum, where the air accumulates beneath the diaphragm in the erect position. Now this is a string of beads. I know I told you about the stepladder sign, but I told you as well that the stepladder sign is more advanced. If this patient is left untreated, we would start seeing the steps of the ladder, because it's not in that condition yet. These are still look like a string of beads. كأنها سبحة. The most likely cause is small bowel obstruction, sure. String of bead sign is seen in patients with small bowel obstruction, appearance of small pockets of gas within fluid-filled small bowel. If they continue, they can transform into stepladder sign. So this is an ultrasound for the donut sign or the target sign. When you take it from another view, it shows you the pseudo kidney sign. It's like almost like a kidney. What is this sign pathognomic of? Intussusception. Very easy. Okay. Do you guys see the intussusception here? Where is the target sign? Let's start with the left image. We'll mark it. Don't worry. So this is the target sign, and we have an intussusception here. And these are the dilated bowels because we have an obstruction. This is the aorta. It's white, most likely because they inserted the contrast. And these are the muscles. This is our target sign. So moving on to here, these are kidneys. We got this might be the diaphragm, the start of the diaphragm, or some part of the spleen. And this is another kidney. He has a contrast, and this is the target sign. It's very clear and easy to diagnose. 1 and 2. All right, we have this. Are you delivered? Yeah, it is delivered. True. And we see this image. What do we see in this image? What is the view first? View. What signs do we have? We see an air accumulating upwards. We see the patient is on his lateral decubitus. Nice. Is it left or right? To the left, yes, because we see this R here. So the patient is giving the X-ray his back. His left shoulder is on the bed. His right side is upwards, and air is accumulating here. Why is that? Perforation, yes, leading to pneumoperitoneum. We do this, the lateral decubitus position, to make sure that it is a perforation. If it wasn't, or maybe it was a gastric bubble or something, otherwise it wouldn't have moved. So when they put it on the lateral decubitus, it moves to this side. If we flip the patient to his right lateral decubitus, we'd still see it upwards. Easy. Who wants to read the case? We don't have much left now.
43-year-old woman present to the emergency department with persistent 8 out of 10 right upper abdominal pain and vomiting. She notes associated mild pain around her right scapula. She states that her pain began 6 hours prior, and she doesn't remember any precipitating factor or trauma. She does recall having intermittent, less severe episodes of abdominal discomfort over the previous year. She mentions that taking antacid doesn't help with her recurrent pain, which occurs after large meals and resolves spontaneously. She takes combined oral OCBs and has history of obesity and non-insulin dependent diabetes. She denies chest pain, heart pain, lower abdominal pain, diaphoresis, and dizziness.
What is the modality of choice for this patient?
Okay. Ultrasound.
Why? What are you suspecting?
Uh, I am suspecting cholecystitis. Okay.
Okay. Okay. Cholecystitis is a good diagnosis. Yes, the modality of choice is ultrasound. It's a gold standard for diagnoses. And you see this image. So what best describes it? Is it a diffuse gallbladder wall thickening, or anechoic lesion with posterior acoustic enhancement, or hypoechoic lesion with hypoechoic posterior band, or echogenic lesion with posterior acoustic shadow? Echogenic as in hyperechoic as well. Which one would you say? Someone says D, someone says C. So this is the gallbladder. It's not a lesion. It's normally here, and this is the biliary tract. So it's not a hypoechoic lesion with a posterior hypoechoic band. No, this is a hyperechoic, and it's actually uh, isoechoic. There's not much to worry about, but here is the lesion, and it is leading towards the gallbladder, the duct, the bile duct for the gallbladder, and these are echogenic. So these are hyperechoic with posterior acoustic shadow. Why are they hyperechoic? Because they have a higher density. Why is there a shadow behind it? Because the ultrasonic waves are not reaching all the way back here. They're being blocked here. So it blocks them, it creates a shadow behind it. What is the most likely diagnosis? The gallstones, yes, it's not cholecystitis. So it could be tricky, but the ultrasound will give you the clear etiology, the clear diagnosis. All right, another image here without a case. What is the modality that we see here? Okay, the modality is ultrasound. What best describes the lesion? Is it a diffuse gallbladder wall thickening, anechoic lesion with posterior acoustic enhancement, hypoechoic lesion with hypoechoic posterior band, echogenic lesion with posterior acoustic shadow? B, yes, it's anechoic. It's pitch black. It's not darker than anything next to it. So it's not hypoechoic, it's anechoic. Yes, B. What is the diagnosis? It's a liver cyst, yes. Good job. Good. One more case. What is the modality here? Is it a barium swallow or meal, follow through, or enema? I told you about follow through, right? It's a meal. Anyone else? What is a barium meal? Can you answer this? Swallow. Okay, what's the difference between swallow and meal? You swallow a meal. Yes, meal is for stomach. So after having the meal, you will take the image. But swallow is for the esophagus. When you after you swallow it, right after you swallow it, you take the imaging, and you can even take several images. What is the most likely diagnosis? Adenocarcinoma. I'm very certain that you know why. What's the name of the sign shown with the asterisk here? Shouldering, yes. And that's why we said it's an adenocarcinoma. So if it were smooth tapering of the esophagus, we'd have said that it is a benign condition. But due to the shouldering here, it's like having two shoulders, and the head in between them. So it is very irregular, and that is an indication for carcinoma. Right, one more case. I'll be reading this one quickly. A 6-month-old, previously healthy boy was brought to emergency department for clear emesis of 1 day, no history of fever, diarrhea, irritability, or trauma. He's no history of anything. On exam, he appears well with normal vital signs and with a benign physical exam. Abdomen was soft to palpation with normal bowel sounds. Patient was treated in the emergency department as a viral gastritis. He tolerated oral fluid, and was discharged home. Parents returned because emesis continued. On his second visit, a rectal exam revealed blood in the stools. So it's coming on and off. When he was at the hospital, he was fine. Everything seemed good, but he still has emesis. This is a case of intussusception. This is how it usually presents. So the intussusception can happen and can be relieved. The child can have pain in his abdomen, then get up again and play like nothing happened. What is the name of this sign? We did an imaging, we saw this. Of course, this is much more severe case for intussusception. What is the sign? Surely we put in, we use the contrast. This is a claw sign. The modality is a contrast enema. We saw this intussusception. This is more important than in pediatrics, actually. Yeah, I think we said most importantly, they happen in the ileocolic region. So the ileum enters the cecum. What happens is invagination of 2 parts of the bowel. Most likely, it is proximal into distal. Yes. So there's a disruption in peristalsis or any other reason, or maybe polyps or colorectal carcinoma. They happen and they cause this intussusception. The symptoms would be intermittent crappy abdominal pain, vomiting, bloody stool, and the name of this bloody stool specifically is red currant jelly stool. Red currant jelly stool. These are the 4 keywords. Intussusception, it is idiopathic in nature. We hypothesize that something happening, changing the nature of the guts and the movement, which leads to the intussusception to happen. There could be viral pathogens, hypoplasia of the lymph nodes in the terminal ileum. Pathological lead points are pieces of intestinal tissue that protrudes into the bowel lumen, like what I have mentioned just now. We give a conservative management, like the bowel obstruction. So specifically to intussusception, it can be done non-surgically. By air or barium enema should be done before opting the surgery, provided that there is no peritonitis or fistula. Otherwise, we can be complicating the problem if we enter with a barium enema or air decompression. The maneuver is the milking maneuver. This is how it's done. So you do not hold the distal bowel and the proximal bowel and pull them apart. No, you milk the intussuscipium the intussuscipiens outwards using this maneuver. Milk it distally or proximally until it comes all the way out. Thank you for listening. I hope you enjoyed and you found this session beneficial. If you have any questions, sorry if I took a long time. We had a break too. Any question? Okay, I guess you are excused. Oh, you're welcome, Emma. You're welcome. Thank you for listening. Have a great night. You're welcome. You're welcome. Good luck on your exams. Goodbye. Assalamu alaikum.